can see this.
Yes, I think I'll put off my video. Thank you, sir.
Yeah,
So
keep talking now.
yes, my talk was comparing SICS and FACO, and I don't know how they put the other one. I think all these speakers, especially speakers from US, have told how they are using SICS for training and for difficult cataracts. Well, we in India know that manual SICS is great, and this is a work that we had done for the African Vision Research Institute, because in Africa, cataract surgery is not that common. Their cataract surgery rates are almost 1/10 that of India. And all the surgeons there wanted to learn FACO, but then most of the international organization want them to do SICS because they get these cataracts at a very late stage. So they are PLPR or hand movement cataracts. And so we had done a meta-analysis to compare SICS and FACO. Next, please, sir. Well, we know FACO is the king of the cataract surgery, as lion is the king of the jungle. Next, please, sir. But the manual small incision surgery, like the Royal Bengal tiger, is, well, a royal surgery in its own right. And we have seen that by presentations done by Dr. Nilutparna, Dr. Aarti, on Dr. Sahu, Dr. Boramani's newer techniques of customized incision cataract surgery. Next, please. So in the meta-analysis, we had used the Der-Simeon-Lard method. And I'll not go into the details of this, but the random effects modeling was used. And we looked at the databases of PubMed, Cochrane, and Scopus. We also looked for non-English language manuscripts. And there were a few in Chinese and Spanish. And well, those which were not indexed also on SICS and its comparison with FACO. Next, please. Well, when we looked at the results, in total, there are 84 studies, of which 30 had been published in PubMed index journals, 38 another journals, and 2 in local journals. Of these, 11 studies had a direct comparison between FACO and SICS, of which 6 were randomized controlled trials. 3 had direct comparison. 1 was with near vision data, 1 with subluxated lenses, 1 with immature cataracts. And there are 2 special studies, one by Khanna et al., which is from LV Prasad, and which compares SICS and FACO in their learning curves in a large residency training and fellowship. And there is another by Dr. Haripriya Arvind, which compares it in a high volume setting with almost 25,000 sample size. Next, please. Well, so these are the 11 studies, and it's a matter of pride for us that all of them are from the Indian subcontinent or Southeast Asia. One is from Nepal, and the rest, all of them, are from India. And they have all been published in some of the most prestigious and journals which have the highest impact factors. Next, please. So these are the 10 things on which we did it. One is look at 618, unaided and aided, because that is the WHO criteria for good outcome after cataract surgery. We looked at BCVA 69 because that is the driving license standard in India, in Europe, and the US. 660 because at that point of time, that was the blindness standard. Astigmatism, intra-op complications, post-op complications, endothelial cell loss, time taken for surgery, cost of surgery, and nowadays with multifocal lenses, it's not just the distant vision, but we are also looking at the near vision. Next, please. So here, if you look at it, there is a dotted line and a straight line. The dotted line is the line that shows us our result. The straight line shows us unity. So if this diamond, which is there right at the bottom, If this diamond touches the straight line, that means there is no difference between the two techniques. So we can see that at the 618 cutoff, there is no difference between phaco and SICS. Next, please. Even for unaided, of course, phaco is giving slightly better unaided near vision. So the diamond is slightly on one side, but again, it is not statistically significant. Next, please. If we look at the best corrected vision at 6.9, again, there is no difference. Next, please. But if we look at unaided vision at 6.9, then there is a difference, and the diamond is just on one side. So phaco definitely gives better unaided vision than manual SICS. And here, of course, there is a difference. And perhaps now, once we have 2 mm SICS, this difference may go. Next, please. Again, at the 660 cutoff, there is no difference. In fact, perhaps SICS is safer. Next, please. But there is a big difference in astigmatism, because for astigmatism, phaco with its 2 mm incision gives lesser astigmatism as compared to SICS. Again, with Dr. Sahu and Dr. Boramani's technique, this may change. But at this point of time, a 5.5 or a 6 mm SICS gives definitely more astigmatism than phaco. For intra-op or post-op complications, there is no difference. Next, please. Again, post-op complication, even when we have learning surgeries and high volume surgeries, which is in the residency training program, as a doctor was saying, from Denver, we find that SICS is definitely safer. So there is a difference here. Next, please. Even for endothelial cell count, people used to think that SICS is done in the anterior chamber while phaco is done in the back. And in phaco, sodium hyaluronate is used. Even then, there is no difference. And in some ways, SICS is safer, perhaps because of the bigger incision. Next, please. Well, the time taken we know is less, but then of course we had fantastic surgeons presenting. So we know that in the long run, there is no great difference as far as time is concerned. But then when you are doing 30, 40 surgeries, well, manual SICS is definitely faster. Next, please. Again, for cost, manual SICS is cheaper. The reason being in phaco, it is the capital cost of the machine. And then, of course, the recurrent expense for the consumables and for the maintenance of the machine. Next, please. But this is one thing which we found new, and I think this is where a lot of research now is needed, is near vision. 81% of SICS patients had unaided near vision better than in 18 as compared to just 20% in the phaco group. And the reason is the astigmatism, which caused slightly impaired distant vision, gave rise to better near vision. Next, please. So the meta-analysis revealed no difference between SICS and phaco on best corrected and unaided 618, 660 cutoff, even BCVA 6.9 cutoff. There was a small difference in unaided 6.9. There was no difference in endothelial cell counts, intra-op, post-op complications. In fact, SICS was safer for beginner surgeons. And of course, the astigmatism was lesser for phacoemulsification. Next, please. So both techniques are similar. There is another meta-analysis done by Zhang Jie, Feng Wai, Kai Jie et al. In them from China, they found similar results, but they also said that SICS had more astigmatism. But they looked at only 6 randomized controlled trials, and they did not go into the details of complications, learning curves, and surgeon time. Next, please. phaco gave lesser astigmatism for sure. But this lesser astigmatism, they got 6/6 unaided for distance, but it compromised their near vision. We have seen so many of our phaco patients. We are very happy because they see 6/9 unaided the next day. But they are not happy because now they can't see their mobile phones, its messages, or the newspaper without specs. And unaided near vision is important not just for literate people or doctors like us, but even in illiterate rural needlework, cooking, cleaning, answering phones, and differentiating currencies. So while we say astigmatism is an issue differentiating the two techniques, it does seem to have much impact on functional vision. Next, please. And in fact, as all the earlier speakers said, SICS definitely has an edge. The operative large astigmatism is there. Toric IOLs are not needed in SICS, as Dr. Aarti showed from Dr. Boramani's CICS presentation. And as we saw in the presentations from the US, black cataracts, poor endothelial cell counts, Dr. Susan's on Fuchs endothelial dystrophy, very old patients, or more than 180 degrees subluxated lenses, or lens-induced glaucoma. Well, manual SICS is definitely superior. And we have this from Dr. Venkatesh and Dr. Arvind from Arvind Eye Hospital. Next, please. So both of them are comparable. Each has its own merits. And this is what all our previous speakers said, and what Dr. Sahu also emphasizes, is it is the surgeon and the technique and the cataract which has to be chosen on its merit. And we shouldn't blindly go in just because one technique is more expensive or is more high-tech. Both of them are royal techniques in their own right, and both of them give the best kind of vision to the patient. Thank you. And special thanks to Dr. Boramani and Dr. Aarti for